We are live, ma'am.
Yeah, thank you. Uh, Dr. Anna, can you stop sharing because
Yeah, sharing, no? Yes, yes, yes.
yeah, thank you.
Praveen.
Good evening, everyone, and welcome everyone to No Thrombosis National Workshop. So today we have our course director, Dr. Subhash Kaul, and I'm sure everyone knows of him. But let me introduce him a little bit. So he's a senior consultant, Department of Neurology, KIMS Hospital, Hyderabad. He's a very highly skilled neurologist with almost more than 40 years of experience in medical field. He has 105 publication to his name and contributed to 20 book chapters. He's delivered more than 300 lectures, including orations, in last 25 years. He has been PI of various clinical trials, national and international, and also ICMR funded trials. He has been expert reviewer and member of editorial board for different journals. He has 30 years of teaching experience in neurology and trained more than 50 students in DM neurology. With regards to awards and honors, he has received State Teacher Award by Government of Telangana. He has been past president of Indian Academy of Neurology, Indian Stroke Association, and Andhra Pradesh Neurology Association. He has done his fellowship, Jacob Javid Stroke Fellowship from USA, and fellowship of American Heart and Stroke Association, and fellow American Academy of Neurology and Royal College of Physicians, Glasgow. Welcome, sir.
Thank you.
We have our moderator for today's session, Dr. Praveen Kumar Yadav. He is a consultant neurology, KIMS Hospital, Hyderabad. He has finished his MBBS from MKCG Medical College, Orissa, MD from Osmania Medical College, Hyderabad, and DM Neurology, Nizam's Institute of Medical Sciences, Hyderabad. He has done his presentation in various conferences like APNS at 2011, Econ Hyderabad 2013, API 2006, Guntur, CONY Bangalore 2012. He has also co-authored a chapter in tropical neurology and member of various organizations like IAN ISA 2011. Welcome, Dr. Praveen.
Thank you.
We have our first speaker, Dr. Abhinav Raina. He's a consultant neurologist, Manipal Hospital, Whitfield, Bangalore. He's done his MBBS from Acharya Sri Chandar College of Medical Sciences, JNK, MD from Government Medical College, JNK, and DM Neurology from Sri Chitra Trinul Institute for Medical Science, Trivandrum. From awards and recognition, he has received Young Investigator Award from World Stroke Congress 2018, IAN BARB Quiz 2017 First Runners Up Award. He has been member of American Academy of Neurology, World Stroke Organization, and Indian Academy of Neurology. He has also done podcast with Dr. Andrew Wilner on Neurology Time, and he has various publications to his name. Welcome, Dr. Abhinav.
Thank you. Thank you for the introduction.
We have our second speaker, Dr. Vinayaka M. He's a consultant neurosurgery, spine surgery, and interventional neurosurgery, Kaveri Hospital, Bangalore. He has worked experience over 10 years and operated many cases. He has also received award All India Torrent Young Scholar Neurosurgery Runner-Up Award. He has presented paper and has played a key role in organizing the 6th CVD Live ACNS Winter Seminar. Just a small note, he's currently in surgery, so he will join if he has finished surgery, or else we will have one case presentation today. So over to you, sir, to take it ahead.
I'm not able to share the screen.
1 second, I'll stop share. Yeah, 1 second. Now you'll be.
Oh, sure. Okay, and just you can see you can see my screen. Okay.
Yes, Dr. Abhinav, we can see you.
Okay. I'll present a couple of cases. And this first case was quite close to me. After completing my DM, this was one of the first challenging cases I came across, and I still vividly remember this. And this was in 2018. And patient came from the onset of presentations after 6 months to us. So this is a little longer case, be with me. So he's a 20-year-old male. So he's a 20-year-old male. He started with fever with headache and a confusional state. Fever, headache, and an acute confusional state. Short history of a few days history. Goes to the nearby hospital, and this is his CT scan. If you can see, this is a plain CT head, which shows some hypodensity in the left parietal region. Probably the patient would have developed a Wernicke's aphasia because of that would have been interpreted as a confusional state, but had a fever, headache, and a confusional state. This was the post-contrast CT, showed a more wedge shaped in the vascular territory, likely non-enhancing wedge-shaped hypodensity, likely to be a potential infarct in this patient. So day seventh, he continues to worsen. He has a severe headache, persistent fever, and he seems to be now getting drowsier. They shift him to a newer hospital. They repeat an imaging. Now this is now a subacute infarct probably. That's why we are seeing this post-contrast. This is a plain T1 MRI, which shows some T1 hyper intensity is likely a hemorrhagic transformation. And what we do see is a new intracranial space occupying lesion, which is iso intense to in the T1 sequences. This is a flare sequence. We do see a this thing hypo intense with the surrounding hyper intense rim. This intracranial space occupying lesion. In addition, that hypo density, which was seen in the previous MRI, the post contrast, it's probably not enhancing, maybe a subacute blood only because it was bright on T1. But the lesion, which was showing a new hypo-intense intracranial space occupying lesion, is also not showing enhancement. You can see this. Uh, Probably a intracerebral bleed. Probably an intracerebral bleed. This was the crude MRI of angiosequences image. I will not waste time on this thing. Was probably normal. It was a venogram which we had taken a picture. Didn't show any obvious. If you can just I'll bring your attention to the superior sagittal sinus, which seems to be quite open and patent in this thing. It's important for the later images. And now the patient undergoes further treatment here, probably on antiplatelets, was receiving antibiotics, was started on a meningitis treatment. Symptoms persisted, fever with headache, sensorium was fluctuating plus and minus. They decided to switch to a newer hospital. He was not getting better, almost 1.5 months into illness. When he goes to another hospital, they decide to repeat an imaging. Again, that gyral bright lesion is seen. The gyri are probably showing, still continuing to show hemorrhagic transformation, subacute infarct. Now that intracranial space occupying, which was hypo on T1, now it's become bright. What we do see is a new lesion adjacent to it in the deep white matter, high frontoparietal sections. So another new lesion has come up. This is probably plain T1 weighted image only, which is showing the margins being bright and the central hypo-intense lesion. I bring this patient also underwent again a venogram there. In this venogram, now we fail to see the superior sagittal sinus. He underwent a diagnosis of cortical venous sinus thrombosis. CSF was done, was sterile, but BioFire showed positivity for probably this thing, Epstein-Barr. Patient was continued on ceftriaxone 2 grams. Along with that, he was on vancomycin and meropenem and acyclovir, along with anticoagulation. So you see this two lesions, intracranial space occupying lesions here. What next? But patient is not showing signs of improvement. He is continuing to worsen. There has been this is now, it started in Jan, in the month of later half of Feb, he shows some improvement and then has an acute relapse. Now again, he started having acute worsening headache with fever, with drowsiness. Now he's shifted to Delhi. And again, they repeat an MRI. Now we are finding another new lesion. Again, now this is a frontal parasagittal lesion, bilateral frontal. Now this is showing um, heterogeneous intense lesion. But again, if you see, it's in the distribution of the anterior cerebral artery. There are some dark hypointense lesions, whether they reflect a hemorrhage or not, possibly. But it is in the bilateral ACA distribution. What's happening to those large hemorrhagic lesions? They are showing some resolution, perilesional edema, and the wedge-shaped infarct is not showing much mass effect. It's also showing some degree of resolution. These are the uh, coronal images, T2 weighted images. Again, heterogeneous lesions in and around in that ACA territory. Uh, I'll go forward. Again, these are T1 non-contrast images showing some bright signal suggesting as a possible subacute hemorrhage also in a hemorrhagic transformation. Again, the same. Post-contrast, it did show some sulcal enhancement in the frontal, mesial frontal region, in the sulci. But other than that, nothing much remarkable. They repeat a venogram. Superior sagittal sinus is still not seen, and he was continued on anticoagulation and antibiotics, the same meningoencephalitis cocktail anticoagulations. And despite all the tests, not much major changes in the treatment from the previous hospital. Apparently, the patient improves. He feels the headache is better. Fever has become intermittent. Sensorium seems to be better, but he's an apathetic state, in more akinetic mute. He had some frontal executive dysfunction also because of the ACA territory lesion. Now, in 2 months later, in the month of April, so he was more or less getting a little bit better or static. Then in the month of April, he again has a relapse. Fever starts with the fever, headache, vomiting, and drowsiness. Now, what does the MRI show? MRI shows this time now it's in the right parieto-occipital lesion. Again, T2 flare, hypointense lesion. The bilateral mesial frontal lesions which were there, it is somewhat getting consolidated into a more homogeneous hemorrhagic, large, well-defined hemorrhage. But now this MRI shows a new right parieto-occipital hemorrhage. Again, showing it right. And if we go back, the previous left parietal hemorrhagic lesions are resolved. Again, the coronal sequences showing the same thing. Sorry for the miniature images. I'll skip that. This is the plain CT scan. Now we can really appreciate, because hemorrhages can give various signals in T1, T2, very difficult acute, subacute stages to differentiate. CT is very simple, easy. We can clearly see it's a large right parieto-occipital bleed, and we can appreciate the resolving bilateral mesial frontal hemorrhagic lesions. Okay, so this is the CT again. Given anti-edema measures, his anticoagulation was probably discontinued. May month comes, he has again fever, headache, vomiting. He improves and then worsens, improves and then worsens. Depressed sensorium. Guess what? Repeat CT, another new bleed in the right front lesion. So he's been every month getting a new bleed at one site or another. Bihemispheric, large lobar bleeds, had a potential probable superior division MCA, left MCA infarction also, and the superior sagittal sinus was not filling in the previous Feb month. Nobody does an angio, again gets hospitalized with every worsening. Again, anti-edema measures, and then he shows some improvement. Comes June, this time fifth worsening. Again, fever, headache, and vomiting. And guess what? Surprise, this time there's no hemorrhage, intracerebral hemorrhage. There's a subarachnoid hemorrhage, mainly in the right sylvian and interpeduncular fossa. And now we have a patient who has had a stroke, who has had multiple intracerebral bleeds, and who has had a subarachnoid hemorrhage. And this course is spread over from January to May, and intermittent fever he's getting. He doesn't have any constitutional signs. Huh? This is when, in the month of June, he reports to us. He doesn't have systemic signs or any constitutional signs. Essentially, it is a pure CNS disease. An examination, when he is drowsy, disoriented, he has a left lateral rectus palsy, right-sided hemiparesis, bilateral papal edema, and showing signs of meningeal irritation. What to do? I'll just this I now we are reaching the climax. This was his old angiogram done in the month of probably April or May, which was reported as normal. What we do see is some aneurysms in the anterior cerebral artery distribution, as well as potentially in the cortical branches of the M4 branches, probably in the middle cerebral artery. So we decided to have a nice proper CT angio. What I'll show you is a reconstructed image of a CT angio. So the CT angio we did, first thing he comes, we review all the images, we'll take 1 day. Second day, we say you just do a CT angio. What we see is a, in the anterior cerebral artery, classical beaded appearance of the anterior cerebral artery, and we see aneurysms involving the anterior cerebral artery. You can see on the right hand side this classical beaded appearance, and we label the patient as a primary CNS vasculitis. Uh, this is again the sagittal cuts showing the anterior cerebral artery, stenotic segment, then a dilatation, then a stenotic, the aneurysms. And we could see, if you can appreciate, even in the posterior cerebral artery, the PCOM was prominent, so you could see the narrowed segment, then the dilatation, then a narrowing, then a dilatation. So we label this patient as a CNS vasculitis. Again, you can see this appearance, narrowing and then dilatation, narrowing and then dilatation. This was a classic. So this we label the patient as a CNS vasculitis. And and we didn't carditis, surviving 6 months despite having these recurrent bleeds and fever. And he had not, in the last 3 months, he wasn't on much on any antibiotics. Initially, he was treated, could be partially treated, but last 3 months he was on oral for 3-4 days and didn't deteriorate much. We label this patient as a primary CNS vasculitis. He didn't show any signs of any systemic vasculitis. ANA profile ANCA was all negative. We started the patient on pulse IVMP, followed by oral prednisolone 1 milligram per kg, roughly 60 for a month, followed by gradual taper. And we started the patient also on cyclophosphamide. Here we give 6 cycles each month apart. And thereafter, we continued after monthly 6 doses, every another 3 doses. And roughly he was on steroids for at least about 4 years, and he's been now off steroids, and he is walking. He's 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 pursuing his 12th standard, which he had to discontinue, and he plays cricket. Huh? He came to us on a trolley, and he has shown a remarkable improvement. So this was the first case of CNS vasculitis, having a stroke, infarct, large bleeds, and also a subarachnoid hemorrhage. If we have time, shall I go to the second and third case, which will be a brief case?
I think let us first have some discussion on
Yes,
this,
yes,
and then we
yes,
can
yes,
go.
yes.
Praveen, any thoughts?
Oh, that's a wonderful. Oh, the first. In fact, those aneurysms were quite visible in the when you
Yes,
pointed out.
yes, yes, yes. They
Otherwise,
were quite
they was.
visible.
Oh,
They were
in
quite
fact, the bleeding was there also, I suppose, in the proximal
Yes, yes,
vessels.
yes. In the
Therefore,
proximal vessels,
yes,
in
therefore, the
concomitant.
later half, the later images, whether the subarachnoid hemorrhage caused the bleeding, that is ruled out because the bleeding is present here also. Oh,
Yes,
so that's patient was very lucky that in spite of so many bleeds,
even
there was no problem. One thing, do we have a vessel wall imaging at any time?
No, no, we don't have a vessel wall imaging. This was in J&K, sir. I was in Jammu at that time in 2018. Unfortunately, there, though we have a 3 Tesla, but the expertise in vessel wall imaging was not there. I wanted to do that. Also, sometimes hands are tied. He had 5 hospitalizations. Money
Tot-
was also quite, so I had to
Totally agree.
decide on a single most valuable investigation, and I thought after I took a day or two, went through each images, and then I came across this top. He had a huge bundle with him going through each canvas. So I took a couple of days, then carefully this top image came across me. I shared it with my neuroradiologist. I think this looks like a vascular. He said, definitely go ahead with the CT angio if your DSA is an issue. We went with the CT angio. Luckily, it showed a very classical picture. Very
The
classic.
bleeding is very well described, but I didn't know about microaneurysms being a hallmark of vasculitis. That
I,
that
yes, I think
that part I was
no, I think the fact that he was not diagnosed, the longer illness, and hence we could see these aneurysm. If it would have been infective endocarditis, we would have killed him. We didn't give him any antibiotics. We gave steroids and cyclophosphamide, and he improved like anything. His
So, and
alertness,
his cardiac echo and all were normal, right?
were normal. We did a ESR CRP, didn't show very high levels. It
I
was
mean, as you were presenting, I was thinking internally that this is infective endocarditis, but obviously
yes
no infective
yes
endocarditis will go on for 4 years. But a lot of things are in favor of infective endocarditis because these aneurysms, particularly, they are the distal anterior DACA aneurysms, as they say. But then obviously that cannot happen for 4 long years. So I think vasculitis, but he's very lucky that he has done so well, and I mean, he has been first of all diagnosed, and then he has got a proper treatment. Otherwise, vasculitis can have a very disastrous course. So nice case presentation, a lot of learning. Thank you. Thanks a lot. So
yeah.
what maintenance he's getting now these days?
so what we thought of, we'll keep him on a 5 milligram of isolone.
Mhm.
He called me from J&K last. He himself had tapered it to 2.5 some year back, and then last 6 months he's not on steroids. And so far he was on steroids from 2018 till about 2024. And for last, I think, 1 year, he is not on steroids. He keeps messaging. Apparently, the boy is doing okay. He hasn't
And
had any.
his lumbar puncture was also
Lumbar puncture was
normal.
sterile, sir. Lumbar puncture was sterile. The cells were, I think, around only 8. and the proteins was slightly elevated, and what I remember, but it was less than 10 cells.
But
Protein,
anyway,
glucose was normal. But CSF biofire had shown positivity for Epstein-Barr virus. I
right.
don't know how to explain that. Many times we come across a biofire. Maybe he had a Epstein-Barr which triggered a vasculitis.
Yeah. Yeah. Good.
Uh,
Good case.
could we
Yeah.
show that? Could reversal of the bleeding? Did we show it?
I didn't do the angio, so that would have been actually a
Yes,
interesting
that
thing
would have.
to do.
Yeah.
But yeah, but it skipped my mind. He was doing so so well.
I-
He- I think one needs to monitor the disease with the periodic angiograms, at least TOF, to see ongoing active disease. That would be one way of looking, in addition to clinical and ESR CRP. We should have ideally done that to demonstrate the reversibility. Next time, if he says, I will ask to see 6 years down the lane how he's doing. How about the angiograms are showing what is the status of aneurysm? That is a good point, sir. Well,
Very
Those
good. Very nice case.
aneurysms, they look dangerous, isn't it?
yes, yes,
Whether
yes.
don't think we can do anything for them, but the proximal one, which was the last time which has bled, oh, how is it and all? Maybe that would help. If
Yeah,
the patient messages you once more, we can have
yeah,
a just a
definitely.
request to see how the lesions have resolved,
Yeah.
bleeding and aneurysms.
Correct, correct, sir, correct.
According to the books and the literature, do the aneurysms also resolve?
Yeah. Aneurysms have been described in vasculitis, particularly in the tertiary vessels, smaller one. It's because of the vasculitis, the vessel walls becomes weaker. You can have outpouchings, can have subarachnoid hemorrhage, but the resolution of aneurysms, I'm not sure. Maybe
Yes.
they remained the same size, hasn't shown an enlargement, and hasn't bled because probably the once post-inflammation, some fibrosis, it hasn't, the wall hasn't, the sac hasn't weakened and might have. But reversal of aneurysm, probably not. I'll check on that. I'll check on that.
Wonderful presentation.
Very great case. Very, very nice. Thank you. Thank you, Abhinav. Let's go to the next case.
Okay. So next case, this is a simple one, but realizing the importance of doing a vessel wall imaging. This patient, a young guy, straightway coming to them. He was a 27-year-old guy, male. He presented with gait unsteadiness, vertigo, and vomiting. MRI diffusion in the within the 24 hours. It shows a posterior circulation stroke, bilateral cerebellar infarcts. We see clear-cut cerebellar infarcts, which is there. This is the TOF angio, intracranial. Normally, patient comes in the acute stroke period. We do a diffusion SWI flare as a protocol here, along with the intracranial angio. Quick. And here the intracranial angio showed a hypoplastic left vertebral, right vertebral seemed normal here. And the basilar also essentially okay. Probably the right PCA is formed through the PCOM, not well visualized, but grossly normal. This is the once we decided we'll not thrombolize this patient, then subsequently we undergo a neck vessel imaging and further imaging to evaluate the cause of stroke. What we see is a TOF angio neck in the left sided, which we thought initially is hypoplastic vertebral, is not well seen, which was seen in the V1, V2 segment of the vertebral artery is seen, but the V3 is not seen and the terminal V4 segment is seen. So we got a little suspicious. No, V3 is not seen. A young guy, 27, no risk factors, overt risk factors. What could it be? Hence comes the importance of doing a T1 fat sat or VISTA sequences to suppress the fat, to look at the wall of the vessel. This one, T1 fat sat image, shows a crescent sign, clear-cut, bright signal in the wall of the right vertebral artery, which is suggestive of a dissection. We double checked, it's not an artifact. It is seen in the sagittal cuts also. This 3D Vista sequence which we apply to most stroke patients after the decision on thrombolysis and mechanical is taken. And we can clearly see the right vertebral, and there is a bright signal from the wall. So it's a hematoma in the wall of the V3 segment of the right vertebral artery. Then we label this patient as dissection. On the same lines, we go to the third case also on the similar lines. I'll just this is a patient, 30-year-old male, presented with recurrent emerosis fugax, the right eye. He would have a transient loss of vision. 30-year-old coming again and again. I was walking through the corridor, and he had met me previously for one of his relatives. He tells me, "Doc, I'm having a cardiology concern." I'm like, "Why you are having a cardio?" "I'm having a recurrent vision loss." I held his hand. I took him to my chamber. I tell me in detail. I keep having this vision loss since last 1 month. I lose, and it recovers within minutes in the right eye. So MRI brain was normal, absolutely normal. This TOF did show some additional reconstructed image, something odd about the right ICA as it enters the cranium. The TOF reconstructed angio shows a reduced caliber of the right ICA, post bifurcation from the neck, extending up to the cranium. This is the sideways cut. See, this is the left ICA, good caliber. The right ICA caliber is reduced. Very important in such cases to do a vessel wall imaging. And this one was a T1. This one, a Vista sequence, shows a nice crescent bright signal in the right ICA. And before the TIAs, he had a headache, a right-sided headache, and a right-sided neck pain, and clearly shows a hematoma in the wall of the right vertebral artery, suggestive of a vertebral dissection. So in a young patient, in the acute setting, we need not run the whole complete vessel wall sequences. Sometimes just applying a Vista sequence or a T1 fat sat in the neck, very important, in the neck, particularly in a younger patient where there are no overt risk factors for the stroke, one should rule out a dissection as an important cause. Then he underwent a proper CT angio. Unfortunately, those images we don't have. He has had an old aneurysm in the V1 segment of the vertebral artery, and he had some acute pain in some few years back, for which he was admitted. Cause could not be found. He never had a stroke. He only had a TI. So these are the two cases regarding the vertebral dissection and the importance of T1 Vista sequence.
Yeah, thank you. In the previous case, she had a stroke. How was the outcome of that cerebral stroke?
He recovered.
He recovered.
And
he was not thrombolized.
That he didn't have further thrombolized. I don't have the flare sequences because flare it had already evolved on the flare sequence. It come around the borderline 6 hours.
Okay.
And the right vertebral flow could be seen. I'll go. The infarction, the dissection was in the right vertebral side, which was
Yeah.
covered,
And
and
yeah,
flow could be seen distally.
that's right.
He didn't deteriorate.
In the other patient, he had a TIA. TIA in which distribution he had,
Yeah.
causing a visual. It was a vertebrobasilar
The right
distribution.
ICA, the right ophthalmic, right ICA, sir. He had amaurosis fugax of the right
Oh,
eye.
but which vessel dissection it was? That's what it was. Which vessel was
The right
dissected?
ICA, sir. Internal
ICA.
carotid, right internal
ICA, not
carotid.
vertebral, but
Dissection.
ICA.
ICA, not ICA, sir.
Yeah,
ICA.
correct. And but fortunately, it was only TIA stage. It was not.
Correct, sir.
He didn't get a stroke.
He didn't get a stroke.
Yeah. And
Did we get any? Sorry, sir. Yeah, go ahead, sir.
so you put him on only antiplatelets, right?
Both the patients we put on anticoagulation for 6
Okay.
months.
And did both of them have headaches or no?
The first patient, the first patient had headache. This patient had some time back, a month back. Since 1 month, he was having recurrent TIAs. He's a marathon runner. He would run 10, 20 kilometers. He had a headache, acute headache, which he had dismissed. And but headaches subsided, but he started having these TIAs. The previous case, he had a headache with followed by a stroke, which was there. But headache wasn't, it was a mild, he said, I'm feeling some pain. It wasn't a thunderclap headache, uh, just a pain which one could dismiss as not important.
I think the point is well taken, that we have to always think of this very important possibility. I think dissection is much, much, much more prevalent than what has been taught to us. It is just a question of looking for it. And no doubt when there is no risk factors, but even in risk factors, people with hypertension, diabetes, dissection still is a possibility, because that also those are also vasculopathies. So many times the mechanism is dissection, even though they have got hypertension and diabetes. I think both these cases, they are lucky that they have recovered both of them. In fact, probably Praveen may remember, uh, one of the recent patients of dissection which I saw did not even have stroke, just headache. And the patient as well as doctor both are lucky if it is detected before the stroke occurs. Because if the stroke occurs and later on you realize that one had missed it, it's bad for both. So, if we have to be very alert for this possibility. Thank you. I think you have really shown us very, very good cases. Praveen, your comments.
Yeah.
Yep. One point I would like to add, as you were presenting the last case in which he had headache followed by TIA, we had a recent very rare case in which the patient had an elongated styloid process, which was compressing the ICA, and it caused a stroke. It was such a rare thing, and the radiologist he himself picked it up. He showed us that how it was compressing, and it precipitated the stroke. Therefore, definitely in young, we have to keep on searching for the cause.
Yeah.
No, we now routinely do a neck vista sequence as a part of an evaluation for and not an obvious cause of stroke. When we are doing a neck vessel angio, along with that top neck, we do a vista sequence also parallelly. Almost all cases by default.
How much time does it take, sir? Because from the cover, the arch of the aorta, neck, do we do on the acute or after a day or two? How do we do it, sir? Because
This we do, sir, post-thrombolysis. Post-thrombolysis, we're very strict. When the patient comes, stroke protocol, diffusion, SWI flare, and intracranial angio. If patient is undergoing a thrombolysis or a thrombectomy, further angio after that only. In this and further neck angio takes about 15-20 minutes, and additional vista another 5-10 minutes. So that will delay the. So we don't do that. The decision is done on the initial sequence. Once the thrombolysis is done, patient is stabilized. Before shifting to the ICU, which is in the first floor in our hospital, we take the patient back to the MRI, do the neck angio and this vista sequence, and then take the patient back.
Paul sir always says, definitely in strokes, if you're not find a cause, we should image the arch and the neck vessels.
I still remember one of the cases, patient developed a stroke, was terribly restless, and because had a left MCA, aphasia, the importance of arch, had a aortic dissection which had extended to the common canal. We were lucky we didn't thrombolize. The radiologist will say, this arch is looking a little funny. Something is there. No, wait, don't thrombolize. And there was a aortic dissection. And patient was terribly restless and couldn't communicate. We were sedating him. Why is he not for the angio? And then we did a CT angio. He was terribly restless. We wanted to do it fast. We sedated, took them to the CT. Luckily, we did a CT. MR can sometimes miss a aortic dissection. Not good. That patient, we did a CT angio there. MR is easy. We don't have a DM residence neuroradiologist. So at night time, patient comes stroke. We want to be absolutely sure. MR is easy. CT stroke window changing is so I do that when I'm around, but that patient during daytime they came. I still remember had a aortic dissection and came in the acute window. But that patient succumbed. She died.
So thank you very much. I think you have really shown us very interesting cases. It has opened our windows of thought. And Praveen, anything else before we call it a day?
No, sir. Always listening to these challenging cases always makes the day brighter, I would say, the night or whatever. Yeah.
Yes.
Because all cases, we see that it seems that we have not seen anything.
All cases are different. All strokes are different. And just, when we say that I have a lot of experience, I want to say it is still less. You have a lot of experience, but it's not enough because there is no limit for experience.
Not at all.
The 100th patient is different from the 99th patient. And so thank you so much, Abhinav. So can we give back to the organizers?
Yes. Thank
you for the wonderful presentations.
Thank you. Very wonderful. Yeah.
Yeah, thank you everyone. Thank you, sir. Thank you, Dr. Abhinav, to have such interesting cases, and thank you to the moderator and sir to have a very good discussion. I guess we don't have our second speaker, unfortunately. I guess he's still in surgery, so we can end this call with sir's permission with this meeting.
Thank you.
Thank you. Good night, everyone.
Thank you. Bye-bye. Thank you.